Good morning, everyone.
Good morning.
It's nice to see so many return faces and people that were with us in 2018 for the conference, and also a lot of new people, both from centers around the country and also from our St. Louis communities, so welcome. So a lot of you were even here with us, but I just wanted to lay a little bit of background for today and tomorrow's conference by talking about what we did in 2018. So as John said, the Knight Alzheimer's Disease Research Center held a workshop entitled African American Participation in Alzheimer's Disease Research Effective Strategies. Very much like this one, it was funded by the NIA, and the Alzheimer's Association provided funding. And we had representation from all the ADRCs, and 300 persons were total attendance. And it was a real mix of academic and community audience. And it addressed the impact that African American underrepresentation in research has on the field of ADRD, including lack of applicability and generalization of the research outcomes to the groups that are not part of participant pools. So at that time, and this may have changed a little, but probably not so much, we discussed the current state of African American participation in research. And the percent of African Americans in ADRD research doesn't match the percentage in the US population. At the time, it was 7.3% versus 13.4%. And per one of the author's papers, African Americans had a 60% greater chance of attrition. So even after people were recruited and joined research, they may be dropping out for various reasons that we needed to explore. And even when they were in studies, they were less likely to participate in all of the ADRD protocols. And we think for the science, all the protocols are so important, right? So for example, although 12.6% of the NAC clinical and cognitive data were from African American participants, only 3.6 were brain autopsy donors. So why does it matter, right? It's not a goal just of our ADRC network, and it's not just a goal of the National Institute of Aging, but of the National Institute on Health in general. And it's important. We're not just trying to meet random guidelines, but we want to promote generalizable results, advance knowledge base, and create innovative treatments that we're sure will benefit all. And it's not just an ADRD problem. Other areas of research and clinical trials apparently face the same struggles. So when we're talking about health disparity research, we need to think about three stages or three things. First, detect. Is it really there? Maybe there are or aren't disparities. We need to study so we can know that. And two, if there are disparities, understand the why. And then, if we know they're there and why they're there, then we know how to take action to reduce disparities. And that may not be something we can do in small silos. We may really need to advocate for system-level change. And as a field, we also determined at that workshop that we need to determine if disparity is a product of biological differences, social determinants of health, or a mix. And as I recall, there was some robust discussion around that, and I think likely there will be again today and tomorrow. We determined that there had been levels of improvement of African American recruitment in ADRD studies, and we had identified as a group themes that influence African American beliefs about participation in clinical research that echoed at the workshop. Experiences, of course, of unequal treatment and racism, cultural trauma from historical and present occurrences. There were some things related to racial identity and cultural norms. And then there was a real impetus back on researchers, the importance of cultural competency and representation both for the recruiters, but also for the researchers. If you have competent recruiters and you turn them over to incompetent researchers, you lose everything that you've been working for. And it was discussed that we need to determine at which level the challenges exist so the remedy occurs at the same level. I think maybe this was Crystal Glover, but it was discussed the macro level, the legal, the political, the social, and historical barriers. That's one place we can address problems. The meso level, that's our institutions and the community. How are we doing, like the provost talked about, connecting with the communities where we are? And then, of course, things at the micro level, individual, family, is it transportation, other types of barriers like that. So that's just a little background. We had some key takeaways that we wrote up. Many of you in the room were probably co-authors on this white paper. It's certainly accessible to everyone. But the key takeaway number one was a very positive thing. African Americans are willing to participate in research. We shouldn't assume someone is unwilling to participate. It's probably us failing, not the interest, right? So we need to create awareness about available research opportunities. Key takeaway number two, recruitment is a science, and we need to treat it that way. We need to carefully design recruitment protocols and measure the outcomes. We need to publish. We need to publish and share the strategies that work. We also need to publish the things that didn't work so people aren't wasting their time. And recruiters and researchers benefit from standardized language and definitions. Key takeaway number three, and for me in working with the community, I think this is maybe the biggest or very big. We need to be transparent. We need to be quick to acknowledge past research atrocities. We need to educate participants about each stop of the research process. We need to clearly explain the reasons for study and the reasons why their, meaning whomever we're trying to recruit, participation is needed to advance the science. We need to share the outcomes of the studies with our participants. And we need to really create a shared vision for the research that is culturally appropriate. Are we studying what people want studied? Is everyone invested? Your team matters is the key takeaway number four. I don't think this is surprising maybe, but we need to have members of our team who look like the communities from which we're recruiting. We need to cross-train our team members so that recruiters understand the studies. And I think that's very important, but I think it's also important that the researchers understand the communities that they're seeking to engage. Both personality and training are important, and we need to provide training that acknowledges racism, microaggressions, implicit and explicit bias. We heard this again and again. Community relationships are everything, right? Long-term relationships require an investment before you come asking people to do something for you. Consider community advisory boards as a research engagement tool. Educate care providers within communities you're recruiting about brain and health and ADRD. Develop partnerships that include building relationships with community cultural brokers and determine the community's interests to develop research programs that address their needs, not just our needs. And incentivize, I'm big on this one too. We need to think about how to incentivize people in research. That includes things like payments for visits. It may include free transportation, sharing results, or it might provide a health service that the community says they want, like a diabetes screening. Consider using various research approaches like focus groups, cross-sectional surveys, and key informant interviews to discover what the community you want to reach thinks is culturally appropriate incentives. And then you got to talk to the IRB to be sure that everyone's, following the rules and meeting regulatory standards. And tools and materials that we use are important. It was discussed, consider using large electronic health records to help recruit potential participants. We need to use straightforward messaging tailored to the group that's being recruited. Photographs and infographics and messaging can make educational and recruitment materials more accessible. And we need to partner with community participants and other stakeholders to develop culturally appropriate tools and materials. Now, moving on to next steps, which is really what today and tomorrow are about. We need to adopt uniform language and standards of procedure to use in the science of recruitment, to create a manual of best practices with a goal of sharing this with all the ADRCs and allowing for collaboration. We need to, host future workshops that provide topic information in advance to promote discussion and include African American community members as speakers. We need to ask each ADRC to engage their stakeholders, participants, and community partners on the appropriate ways to determine linguistic and cultural differences between African Americans and other races as well within African American cultural groups. We need to develop a robust program related to addressing health disparities linked directly to social determinants of health and structural vulnerability that is often seen in the African American community. We need to learn new processes of community and participant engagement to increase the likelihood of receiving additional funding and support for these types of initiatives. We need to really create a shared vision related to increasing health equity of African Americans and other under-resourced communities, we're moving that way today and tomorrow, that empower active engagement in the research process from design, implementation, analysis, and dissemination. And we need to develop new processes to educate the next generation of diverse researchers to engage in ADRD research. So I want to say progress is happening, probably a lot more even than I'm aware of. But the Alzheimer's Association put out an inclusive language guide. Many of you in the room, I know Ganesh Babulal from our center was involved with that, and it's really good. If you haven't looked at it, I looked at it again while I was preparing this, and there were so many reminders of ways that I need to look at this before I write anything up. It's very helpful. We're having another workshop. We're calling it a conference, but here we are. We're including more community voices, and we're going to hear from many of you about what your next steps are that have been taken. And more locally, at the night ADRC, John Morris created a Health Disparities and Equity Corps with our inaugural lead, Dr. Joy Ballsbury. Dr. Morris and his wife endowed our African American Advisory Board, so its work can really get stronger and go on. We've had a lot of internal conversations about language. Just as an example, thanks to colleagues' feedback, we now always try to say people who self-identify as African American or Black. And we have created, with many colleagues across the network, the SS Dyad, which you will hear about later, to incorporate social determinants of health into our research. And we listen to you. For my last little bit, instead of me talking from the academic standpoint, I wanted to invite two very special research participants and African American Advisory Board members to just tell you, to set the stage, why they choose to be involved in Alzheimer's disease research. So, Reverend Strong, would you like to come down first? It's my great pleasure to introduce Reverend C. Jessel Strong.
Thank you. It is my pleasure to be here, and when Andrea asked me why did I become a research volunteer, I had to think back, and about 2008, we used to have a ministerial group that met at a place called the Salad Bowl, and the person who spearheaded these meetings was Ida Woodfall. And Ida has a way of getting you to do anything that so she was talking about Alzheimer's, and I had experienced the loss of my mother with Alzheimer's, and so I said, well, I guess if I can help in some kind of way, then I will volunteer. But I didn't know what I was getting into. But I wouldn't take nothing for the experience of being able to be a research volunteer. And I'm just glad that in some small way that I can contribute to hoping to find a cure for Alzheimer's. Thank you.
And I should have mentioned that Reverend Strong is also the vice chair of our African American Advisory Board. And now I want to introduce another lovely research participant and member of our African Advisory Board who has participated in research not just at the night ADRC, but at Emory before us. So Beverly Foster, please come down.
Good morning. It is my privilege to tell you why I participate in Alzheimer's research. Thank you, Andrea, for inviting me. On March 17th, 2006, my mom passed with Alzheimer's. At the time, I knew little more than the name of the disease. I remember at the onset, she would have difficulty coming up with the words that she wanted to say when she was talking. And I remember in frustration, she would declare, "I hate this." My mom was a kind, compassionate woman, raised 5 children, loved and nurtured 11 grands and 5 great-grands. She was an independent woman, active in her church and in organizations, but we noticed that she started getting lost, going back and forth to places where she went all the time. We noticed that as an excellent seamstress, she would take her machines apart and not know how to put them back together so that she could use them. I remember episodes of Sundowners when she didn't recognize us as her grown children, and she would plead with us to take her home because her children were waiting for her. Alzheimer's is an ugly, hurtful disease. Even now, it's difficult for me to comprehend how my own mother didn't know who I was. And she thought my sister was a nice lady who was taking care of her. I started participating in Alzheimer's research, as Andrea mentioned, when I lived in Denver at the Emory ADRC, working with Dr. Parker. I participated in all of the exams, the tests, the spinal tabs, and I also got to help with doing conferences to encourage more African Americans to participate in research. African Americans are leaders in many things, but unfortunately, some of those things are not quite positive. We are leaders in high blood pressure, diabetes, obesity, and other comorbidities. It's important that we participate in research because when we don't get the opportunity to influence the treatment that will be beneficial to each of us. There are many things that we won't learn if we don't participate in research. We won't learn that lifestyle changes in diet, sleep, hydration will slow the progression and hopefully reduce the risk of Alzheimer's. We won't learn that lifestyle changes in diet, I think I just said that. We won't learn the symptoms of the disease from onset to late stage so that we won't ignore them and pass them off as something else. We won't learn that there are resources available, networks of doctors and professionals, and mountains of information that can help us navigate the disease. It's said that knowledge is power. I believe that it's applied knowledge that is power. So let's do what we know. Thank you.